how, oh well, no. These are the objectives. Understand the indications for chest radiograph, types of radiograph performed, radiological terminologies, understand the indications for post-procedural X-ray, be able to interpret chest X-ray. So this is how X-ray is produced, not very important. There are electromagnetic wave that goes through a tube that electrical current has been passed. So no big deal there. So X-rays are generated by placing a film next to the patient. Okay, we'll call it the film or the cassette. The cassette. So it's either you place it at the back of the patient or in front of the patient, depending on which direction that you are taking the X-ray. X-ray passes through the patient and is absorbed by the film. The lower the density of the matter, the more X-ray that will strike the film and turn it black. So, for instance, air has very low density. Okay, it will turn it black. Fluid, secretions, okay, has high density, and it will turn it white. Okay, so the less dense, but the more dense, the more white, and the less dense, the more black. So these are the densities here. So bone will be very, very dense. Okay, so if the X-ray goes to a bone, definitely will turn white. Okay, it goes to water, it's going to be white. Okay, but not as white as the bone. Okay, if it goes too fat, it will be a little dark. Radiolucent means dark. But now, if it goes through air, it's going to be very, very radiolucent. Okay, the patient and the film are placed 6 feet apart from the X-ray. So if you're shooting the film, if you're doing anterior-posterior, then the film will be at the patient's back, and then you stand there well like 6 feet and shoot the film. Okay? If you're doing anterior, then the film will be in front of the patient on the cassette. I think they call it cassette now, or even film. I don't know which one is the modern name for it. And shoot the X-ray, but you have to be 6 feet apart. Okay, so now let's define some terminologies here. Radiolucent means dark. That's what it means. Radiodense is white. Radiodense is white. Now, infiltrate. An infiltrate on a chest film is defined as an ill-defined radio density. Basically, infiltrate means a little white here, a little white there, like here, 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 here. It doesn't necessarily mean anything. It just means there is a little white there, but I don't know what it is. Okay? Infiltrate does not, by itself, does not diagnose any disease. Okay? But if there is anything that you want to associate infiltrate with, you may associate it with atelectasis, but it does not mean atelectasis. It just means a little bit white here, a little bit white there. Okay, so anytime a radiologist sees infiltrate, sees little white spots on a chest film, and they don't know what to call it, they can't call it a disease, they call it infiltrate. So it is an ill-defined radiodensity. Okay? Now, consolidation does not mean anything. Consolidation just means that there is more thick white area like that. There is thick white area in the chest film. It is worse than infiltrate, but I don't know what it is. Because a lot of things can cause consolidation on a chest film. For instance, pneumonia can cause consolidation. Pleural effusion can cause consolidation. Tumor inside the lungs can cause consolidation. Mucus plug can cause consolidation. Aspirated object can cause consolidation. So when you say, well, they have consolidation, therefore they have pneumonia, no, it's not like that. Anytime you see consolidation on a chest film, you have to do more testing to find out what is causing the consolidation. So it does not mean anything. It means there is more white in this area. It is worse than infiltrate, but I don't know what it is. Okay, if you want to find out what is causing consolidation, you got to do more testing. Okay. All right, hypolucency means very, very dark. Very, very dark. Vascular markings, those are the blood vessels. The streaky, kind of white-looking blood vessels that you see in the chest film, those are vascular markings. They are very important as far as interpreting chest film. Okay, you should be able to see them. Anytime you don't see the vascular markings, you got a problem. Like pneumothorax will make you not to see them because then it will be very, 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 very dark. If you have obstructive disease, you are not going to see them as much. Okay, so they're very important to look for when you're interpreting chest film. Diffuse means all over the place. Diffuse infiltrates. So it's a little white there, all over the place. Diffuse infiltrate. Opaque means white. Bilateral means on both sides. Okay? So when a patient has bilateral, diffuse bilateral infiltrates, that's ARDS, for instance. Okay, so that's another way of saying that their chest film is whited out. Okay, diffuse bilateral infiltrates. That would be ARDS. That's the way they describe it on the exam. Okay? Unilateral means on one side. Okay, so this is where we have defined the infiltrate some more. We put more adjective to describe it. What type of infiltrate do you have? Like I said before, infiltrate by itself does not mean anything. It just means that there is a little white there, I don't know what it is. But now we can describe it some more, say, well, what type of infiltrate do you have? So it's very important that you know this because once you know them, you can associate them with disease processes. Okay? For instance, when I say fluffy infiltrate or butterfly or batwing pattern infiltrate, that would be pulmonary edema, right? Because now on the exam, they're going to give you that question, they're going to write, well, a patient was in the surgery, they came out, their family members came to see them, blah, blah. As soon as they say fluffy, you say pulmonary edema. That's all. Okay? Pashy infiltrate or plate-like infiltrate, that will be atelectasis. Atelectasis. Like I said, now if there's anything at all that you want to associate infiltrate with, you can associate it with atelectasis, but it does not mean atelectasis. Okay, when they describe it this way, pashy or plate-like or thin infiltrate, you say atelectasis, for sure. Grand glass appearance or honeycomb pattern or diffuse bilateral radiopacity, that would be ARDS. It's like you're taking glass and then you're grinding it. Okay, ARDS. So if you describe a patient scenario. Once you say, well, ground glass appearance, I say, well, they got ARDS, they got arch. Okay, or honeycomb pattern, arch. Okay? A bronchogram means pneumonia. Okay? Now, a bronchogram is like, here is the normal lung unit here, normal alveolus. So now you get pneumonia, now you have exodus and secretions flooding in here, so that kind of distends the lung like that. Distends the lung, the weight of the fluid inside the alveolus is going to make it to stretch. That's what a bronchogram is. Okay. Pneumonia is infection, and when you have infection, there is increase in the number and size of the goblet cells. The goblet cells, produce secretions. And the secretions will drain into the alveolus and stretch it. Okay, so we associate a bronchogram with pneumonia. X-ray has returned with the result a bronchogram. Which of the following diseases would a respiratory therapist diagnose? And then you say pneumonia. Okay? Peripheral wedge-shaped infiltrate. That's pulmonary embolism. Pulmonary embolism. If you tell me that, I say, well, they got pulmonary embolism. So look at this here. So here's where the clot is here. Pulmonary embolism, that's clot inside the lungs. Now blood is flowing like that. All of a sudden it comes to the clot, it wedges. You can't go past it. That's a wedge. Stops it. Peripheral wedge-shaped infiltrate. Again, they can go well. X-ray has returned with the result, peripheral wedge-shaped infiltrate. Which of the following therapies would the respiratory therapist recommend? How do you treat pulmonary embolism? What kind of medication do you give to them to dissolve it? Blood thinner, right? So you're going to recommend that the patient receives heparin, or Coumadin, or Levodopa. Okay? And then we have concave superior interface border, or basilar infiltrate with meniscus. That's pleural effusion. Pleural effusion messes up the angle between the lungs and the chest wall. So, or the diaphragm and the chest wall, sorry. So this is the chest. Here's your diaphragm, like that. So this is called the costophrenic angle. The costophrenic angle. Now, when you have fluid in here, this angle will look different. Okay, if you look at it on the chest, it will be white. It's supposed to be dark around this area, but it will be white. So you get fluid. Okay? So that's what they're saying. There's two more names for it. They can say blunting of the costophrenic angle. That would be pleural effusion. Or maybe they would say uteration. Nothing here writes very well. Obliteration of the costophrenic angle. That would be pleural effusion. Okay? So remember those words. Indications for chest X-ray. Detect alteration caused by pathology. You have a disease process. We want to see, the extent of the damage. We can take chest film like emphysema. Okay. Determine appropriate therapy. Yeah, we can do that. Evaluate effectiveness of treatment. Determine the position of tubes and catheter. Yeah, for instance, when you intubate a patient, it's always protocol to get a chest film. Okay, getting a chest film is the best way to confirm tube placement. The best way. The quickest way is chest rise and fall. Once you intubate your patient, you start bagging them, you got to see whether their chest is rising and falling. That's the first thing you look for, even before you start listening to breath sounds. And then after everything is done, you got to call X-ray, and then have them take X-ray of the patient to find out where the tip of the ET tube is. Where should we place the tip of the ET tube in relation to the carina? 2 to 5 cm, okay, above the carina. Now, if you don't take your chest film, you don't know. Maybe the ET tube went inside the right man's tent, okay? And then you're gonna cause pneumothorax over there. Observe the progression of lung disease, yeah. Okay, so we have standard views. Posterior anterior is when you are shooting the film from their back, and the cassette or the film is in front of the patient. Okay? Now, that is the best film. Okay? That's the best film. But unfortunately, this type of film mostly requires that the patient can get up and actually stand. You go to they wheel you to the X-ray department, and then you get up from the wheelchair, and then you're going to be able to stand. And then they shoot the film from the back. That's the best film, but not everybody can do that. We have ICU patients that can't even get up. So the only choice that we have is to do the anterior posterior, okay, film. Okay, but this is the best one. Anterior posterior, one thing that is wrong with that film is that it causes enlargement of the heart. When you shoot it, the heart appears to be enlarged. Now, if the heart is enlarged, that is a disorder. That's what we call cardiomegaly. Cardiomegaly. The heart gets enlarged, and what causes cardiomegaly is heart failure. Okay? When you have heart failure, you have fluid overload. And the way that the body compensates for fluid overload is by the heart absorbing the fluid. That's what causes the cardiomegaly. So, in order to be sure that we're not doing misdiagnosis here, when you get your chest film, you're going to do what they call orientation of the film. Orientation, once you hang it, the first thing you want to determine is this a PA film or is it AP film? Okay, that's called orientation of the film. In that way, you're not making misdiagnosis, because if you don't know that it is an AP film, and then you see an enlarged heart, then you call it heart failure, that the patient has heart failure. How do we know that the heart is enlarged? How do you know that? You measure, right? Like that. Yeah, I don't know if you all remember that. Now, the cardiac shadow or silhouette must not be more than half the cardiothoracic ratio. So, if you have the heart like that way, you're going to measure the shadow. So this is the spine coming. So you measure the shadow like that, and then you put your hand like that. Make sure it's not over their chest. Okay? So if the shadow is greater than half the cardiothoracic ratio, then you have cardiomegaly, and you have heart failure, CHF. Okay? All right. We can do a lateral X-ray as well, okay, just to have third dimensional view, okay? You have this, then you want to look at some more to see whether you can see whatever that is wrong very closely, okay? Now, also we can do lateral film for epiglottitis, the neck, epiglottitis. You do that, somebody all of a sudden has acute epiglottitis where their epiglottis is swelling up. You do a lateral film, okay? When you look at it on the chest film, it looks like a thumbprint sign. That would be epiglottitis. We can also do it for a croup. If they have croup, we can do that. For instance, for your information,